All right, guys, so thanks for joining for today's journal club. Today we'll be talking about diabetic ketoacidosis and COVID-19, and my advisor is Dr. Nguyen. We don't have any financial disclosures or any relevant relationships. Our objectives for today, we're going to practice formulating a specific clinical question and understand the study design most likely to yield valid information about a therapeutic question. We're going to appraise the article, discuss its uses and limitations, review important factors in the determination of the internal validity of the study, discuss the applicability, and then consider possibilities for future studies. So one of the reasons why I chose this particular topic is during the few awards blocks I've had during the epidemic, I don't know if anyone else has felt this way, but I felt like we were seeing an increase in kiddos coming in, not only with new onset diabetes, but in DKA as well. So that's why I chose this particular topic. So currently in the United States, there are 1.6 million people living with type 1 diabetes, and this includes about 200,000 people under the age of 20. The highest prevalence is in non-Hispanic white children, and there seems to be equal predominance between girls and boys. By 2050, it's estimated that 5 million people will have type 1 diabetes, and this includes about 600,000 people under the age of 20. Currently, less than 1/3 of all people with type 1 are consistently achieving target blood glucose control. DKA currently accounts for 14% of all hospital admissions of patients with diabetes and 16% of all diabetes-related fatalities. And as a result, annually we're spending about $16 billion just in type 1 diabetic-associated healthcare expenditures. The diabetic ketoacidosis is an acute major life-threatening complication of diabetes. There is absolute relative. So essentially, basically, there's just a deficiency of insulin. You can't get glucose into your cells to be used. So the liver starts breaking down fat and ketones, and after some time, the ketones accumulate and it contributes to a state of metabolic acidosis. So some signs and symptoms of DKA are malaise, and generalized weakness. It can be nausea, vomiting, dry mucous membranes just because they're so dehydrated, decreased skin turgor. They can have labored respiration or crucial breathing just essentially because they're trying to breathe off all the acids they've accumulated. In some cases, you can have that ketotic breath odor, and then in really severe cases, they may present with altered mental status. So DKA is characterized as a blood glucose greater than 200, accompanied by a blood pH of 7.3 or a bicarbonate level less than 15. And I found this table in a Pediatric review article where it can be classified as mild, moderate, or severe, and then that kind of leads the management from that point. About 25% of cases, new onset type 1 diabetics will present with DKA, and some of the precipitating factors are, one of them is infection. There are a lot of different studies that have shown that viral infections can predispose to the kind of tipping people over the edge into developing type 1 and then coming in presenting with DKA. But with known diabetics, some of the things that we've seen time and time again is if they're not taking their insulin, they have insulin pump failure, or they're just generally non-compliant with medical care. So the clinical question for our article we're going to discuss today is the frequency or incidence of diabetic ketoacidosis in children and adolescents at diagnosis of type 1 diabetes in Germany during the first 2 months of the COVID-19 pandemic. And so in PICO-TT format, our population is children and adolescents under the age of 18 in Germany. Because this was kind of a retrospective study, there wasn't specifically an intervention, but there was a particular time period of interest, so that would have been March 13th to May 13th of 2020. They compared it to children and adolescents during the similar time periods of the 2 previous years. And our outcome we're looking at was the frequency of diabetic ketoacidosis at diagnosis of type 1 diabetes. And this was an observational cross-sectional study. In terms of who the primary author is, Dr. Clemens Kamras. He serves on the Division of Pediatric Endocrinology and Diabetology. He also does a lot of steroid research as well. And he has over 40 publications and some that are pending currently. And just in terms of, he has a lot of co-authors, but one of the co-authors is Dr. Beaster. And I'm not going to pretend that I know how to pronounce the name of that children's hospital, but it's actually the home of the Diabetes Center for Children and Adolescents. It's actually the largest center of that kind in Germany. In terms of where, like I said, this study did occur in Germany. It was under the German Diabetes Prospective Follow-up Registry. So it collected information from 217 hospital and medical practices since 2018 and has, it includes nationwide coverage of more than 90% of pediatric patients with type 1 diabetes. And just for comparison, Germany has a population of about 84 million. Data from 2015 shows that 12% of their population is foreign-born. And of interest, of all the 27 European Union states, it actually has the highest percentage of immigrants in its population. There's about 10 million people living in Germany that were actually born outside of the country. And then their under 18 population is about 13 million, and that's data from 2012. In comparison, the United States has a population of about 4 times that much at 330 million. 14% of our population back in 2015 was considered foreign-born, and then our under 18 population in 2012 was 75 million. Currently, Germany is ranked 12th in the world when it comes to the rate of incidence of type 1 diabetes. The total prevalence in 2010 was about 10% of their population, and recent data shows that they had about 270,000 cases of corona and just shy of 10,000 deaths. In the United States, like I mentioned earlier, we have about 200,000 type 1 diabetics under the age of 20. About almost 11% of our population has diabetes, and this includes type 1 and type 2. And type 1 accounts for about 5% of all of our diagnosed cases of diabetes. And then recent data has showed that we've had almost 7 million cases of corona in our country and about 200,000 deaths. And just for comparison, Virginia itself has had about 140,000 cases and 3,000 deaths. So in terms of when, like I said, our study period was from March 13th to May 13th of 2020, so essentially the initial lockdown period. And this will compare it to the same time period in 2018 and 2019. So why I particularly chose this article, like I talked about earlier, thinking that we may be seeing a link between diabetic ketoacidosis and coronavirus. We do know that viruses can be a trigger, but we don't necessarily have a lot of data so far about the link between corona and diabetic ketoacidosis. There was a study, excuse me, completed in China. It was in the Wuhan province that was published in April of this year that showed that COVID-19 infection caused ketoacidosis in patients who were not diabetic. And then it actually induced diabetic ketoacidosis for those patients with diabetes. In the U.S., there was a multi-center surveillance study that was done in conjunction with the University of Colorado, Hassenfeld Children's Hospital at NYU, and another facility in Boston that I'm blanking on the name of. But they looked at type 1 diabetes and COVID-19 as well. They looked at the total number of people in the study were about 64 people, and they were looking at common presenting symptoms and then adverse effects. So the most prevalent symptoms across the board for those with confirmed or suspected COVID was elevated blood glucose. So they saw that in about 50% of the participants in the study. And then the most prevalent adverse outcome was DKA, so about 30% of all patients within the study, and then 46% of those who actually confirmed to have had COVID-19, showing that there may or may not be some link. So in terms of the methods, so our study population included 532 children and adolescents who were diagnosed with type 1 during this time period, and then data was collected from 216 out of the 217 centers. I'm not quite sure why that last center was omitted, because it wasn't mentioned. And then informed consent for participation, and the registry was obtained from patients if they were of age or their parents by verbal or written consent. So they looked at the frequency of DKA and severe DKA and then compared it to similar time periods. And then the parameters were DKA with a pH of less than 7.3 or bicarbonate level less than 15, and then severe with a pH level less than 7.1 or bicarbonate level less than 5. So they utilized a multivariate logistic regression. So this is typically used when you're wanting to adjust for confounders. So confounders are just typically variables that can influence both the dependent and independent variables. So you want to adjust for that so that your data is more valid. And it's also used when your dependent variable have more than one outcome. So in this case, we were looking at DKA and severe DKA. They adjusted for some demographic information. This included age, sex, and an immigrant background. And they considered immigrant background if they had one parent who was born outside of Germany. And the differences were presented as adjusted relative risk with a 95% confidence interval. Just a brief stats review because it's all our favorite topic. The relative risk is the ratio of the probability of an event occurring in the exposed versus non-exposed group. So if you have a relative risk less than 1, it indicates a decreased risk, greater than 1 increase, and if it's equal to 1, the risk is essentially the same in the groups that you're comparing. And with adjusted relative risk, the logistic regression typically gives us an adjusted odds ratio that can approximate the adjusted relative risk when our disease incidence is rare. And it helps us to adjust for potential confounders, which is why it was utilized in this particular study. And so, like I said, they used a 95% confidence interval, and I know we've all seen this graph before. Just of note, if your confidence interval includes 1, it indicates no statistical difference. So I'll talk about that a little later when we go over the results. And then in terms of p-value, just for a quick review, it essentially gives us evidence against the null hypothesis. The null hypothesis usually states that there's no association between the groups or the outcomes that you're looking at between the groups. The smaller your p-value, the stronger there is evidence to reject the belief that there's no association. And for this particular study, they did use a p-value of less than 0.05. And they used SAS version 9.4, essentially this stands for Statistical Analysis System. It's a computer software that allows for mathematical analysis. This isn't the most current version, but it is the version that they used in the study. And so to get to our results. So bear with me, I know there's a lot of information in the charts, but we're going to go through it. So the median age was about 10 years old, and it actually showed a male predominance. If you can see here, the previous 2 years were roughly similar, but 2020 did show a higher male predominance. Like I said, we did look at the initial lockdown period, and it did show that the frequency of DKA was higher than in the previous 2 years. So if you can see here, looking at the frequency of DKA, it showed that it was about a 45% in 2020 versus 24.5% in 2019. This had an adjusted relative risk of about 1.84, and it was statistically significant with the p-value shown there. And then again, versus the 24.1% that was seen in 2018, and that was also statistically significant difference. They also showed an increase in severe DKA. So you can see here it was 19.4% in 2020 as compared to 13.9% in 2019, which was statistically significant at a p-value of 0.03, and then versus 12.3% that was shown in 2018, which was also significant. And then we can look at it broken down by age group as well. So it showed that DKA was highest in the less than 6 age group with an incidence of about almost 52% as compared to 18.4% and 24.2% in the year previous. And like I said, these were as well statistically significant. And then we see that in severe DKA as well, with an incidence increasing, was almost twice as much as it was the year prior. And then this chart essentially just laid out the adjusted relative risk with the associated p-value. Like I said, if you had a confidence interval that included 1, it typically indicates that there was no statistical significance. So looking at the age group, if you look at 6 to 11 and 12 to 18, it shows that there was no statistically significant difference between the years between 2019 as shown here, and then 2018 is shown here as well. Interestingly enough, it did show that there was a difference in the sex in terms of females in 2019, but not so in 2018, and again between males between the years. So we're not really quite sure what's accounting for this difference of why it's significant one year and not the other year. It's not mentioned in the study. Talk about that a little bit later. And then immigrant background as well was not significant in 2019 when you're looking at whether they were foreign born or not, but it was statistically significant in the other years. And then the rest of the table just basically shows that there were significant differences seen between the two groups. So essentially what the study concluded was that there was a significant increase in diabetic ketoacidosis and severe ketoacidosis at diagnosis of type 1 diabetes in children and adolescents, and that there was a significant increase in the incidence of children less than 6 years old, which I thought was interesting because in my personal limited experience, a lot of the kiddos I've seen coming in with DKA and new onset diabetes were actually under the age of 4 and 5. So I thought that was interesting. And so for everyone's favorite portion, this is the part where I am encouraged to have you guys participate. So if you want to unmute yourselves or chat in the chat box, we're just going to go through a series of questions, and I would just like your input. So bear with me. There will be a lot of awkward silences, but bear with me. So first we're going to talk about validity. So did the paper describe an important clinical question, address via clearly formulated question? What are some things that you guys think? Let me see if I can open up the chat box so I can see. So do we think the paper described an important clinical question, yes or no? So one, yep, so a couple of people are saying yes. So I would agree. Yep, absolutely. The primary question was the incidence of ketoacidosis in their chosen population, and we were looking at the beginning of the pandemic, so I think they did a good job of addressing that question. Next question is, were the setting and the subject selected appropriately? What do you guys think? Getting a couple of private messages too, but you guys can't see those. But primarily a lot of people are saying yes. So they specifically chose their time period and then were sure that they were comparing similar children in terms of like their ages and their sex to other children during the same time period in 2018 and 2019. So the next question was, do you think the methods used for collecting the data were described in enough detail? What are your thoughts? Some of my messages, I'm getting some people saying yes, and some people saying no. I'll tell you what I thought. I kind of was in the middle. I said somewhat. I thought that more information could have been provided in how the data was collected. We don't necessarily know if in their registry they were going back in time and looking at data. We don't necessarily know what their criteria was for collecting that data, and if they had any other demographic information besides what was included in the study for registry participants, because like we'll talk about later, that can kind of skew your data one way or the other. And then were appropriate methods used to analyze the data? What do you guys think? And so I agreed. I thought logistic regression was an appropriate choice, just given that we had so many different confounders that we wanted to adjust for, and that we were looking at a dependent variable that was binary. So we were looking at not only just DKA, but quantifying it further and looking at severe DKA. And I thought that the p-value that they used was appropriate. And so next we're going to talk about external validity and how we could apply this. So do we feel that the results are credible, and if so, are they clinically important? What do you guys think? One, do you think that the results were things that we could take for face value, or if the results are clinically important? They can be temporal. Yep, and seasonal variations, absolutely. I don't know if everyone can see the chat, but Dr. Nguyen was saying that for the previous question, she appreciates that the authors chose the same months pre-COVID as compared to during COVID, since there can be temporal and seasonal variations. So I've got one that says the p-values were good for most age groups, but not all. Yep. And then overall, the results were credible. I would agree. And then do we think that they're clinically important, the results that they provided? I got a message that says, I think that it's somewhat clinically important, but more work ready to be done. Yeah, I would agree with that statement. So I said somewhat, I said the results were credible, but just from the type of study it is, we cannot necessarily conclude an association or just infer causality between the two. So there were several confounders that were not considered or included in the analysis, which would be important. One of the things, and I'll talk about this later in the limitations of the study, but we don't really necessarily know a lot of information about the patient population. We don't necessarily know a lot about what their social economic status is, if they have insurance, where they live. Like, do they live in an urban area where there are 4 different hospitals and 10 different, urgent cares or medical centers, versus people who live more rurally and have to travel a longer distance to seek medical care. We don't know a lot of information about their family history, as we know that there's a strong predisposition if you have a family member or first-degree family member with type 1 diabetes, and I think that would be important information to have if you're looking at the incidence of a disease. We also have some information, not a lot of information about their race. We just know that, hey, they may have had a parent who was born outside of Germany, but we don't necessarily have a lot of information in that point. So definitely credible, but I think that there could definitely be room for improvement. The next question is,
Olivia, just to clarify, can you hear me?
Yes,
this is Dr. Nguyen. Just to clarify Kevin's point, if you can go back to table 2. Just looking at the p-values and the relative risk, the ratio. So looking at the different age groups. So the first half of that table, it looks like the RR does not cross 1. So actually for all the age groups, it does seem to be statistically significant difference, but I think the it's only statistically significant on the second half for ages less than 6 for severe DKA. Right. So there is a significant increase during COVID compared to previous years for DKA in general, and also for the individual subgroups based on age, but not for the severe DKA for all of the age groups, just to clarify Kevin's point. But thank you.
So what are you guys' thoughts about where the conclusions justified by the results? So some of the messages I'm getting says that, just based off of the information that they provided. Yep. So I would agree, just given the statistical significance of the results and then the comparison to some other time period of previous years, that I think that their conclusions that they drew were justified just given the results that we do have. And then I think this is the last one. Are the findings of the study transferable to other clinical settings? What are your guys' thoughts here? Does anyone think that this information could be replicated or is important for our patient population in particular? I've gotten a couple of private messages that have said that information was beneficial, but would be difficult to replicate in our patient population. So a lot of the messages I've gotten saying that it would be difficult to replicate in our patient population. Essentially, that was what I said, just particularly given the difference in the patient population and the fact that we don't necessarily have a registry where we'd be able to go back and collect that data. I feel like there would have to be a lot of retrospective data that would have to be collected, and a lot of centers working in conjunction with each other, just because pediatric population is not a significant part of our general population. So a lot of studies would have to, or centers, pardon me, would have to work together to collect some of this data. So just to review some of the limitations of the study, and some of them I had touched on a little earlier. One of them being family history. Like I said, we don't necessarily know a lot of information about family history, so I think that that is definitely an important confounder that I think they could have talked about more. And just generally other confounding factors besides, like we talked about, socioeconomic factors or location. I think parental education is a big one. I think we've even seen that in our own patient population. It's very different when you have parents who have some sort of health literacy. The difference is in when you have parents who have friends or family members who have type 1 diabetes, or even other children who know some of the things to look out for versus those that don't. I've even seen it in a couple of patients that I've seen recently during the pandemic of a mom who has 4 children. Her oldest child had type 1 diabetes. Her middle 2 children started to develop some symptoms of polyuria, polydipsia, and she's like, yeah, I think they might be losing weight. So she happened to check for the children's glucose, and it was elevated, and that's how 2 of her other children were diagnosed with type 1 diabetes. Not in DKA, particularly because she knew some of the things to look out for, but I think parental education and health literacy would be something important to keep in mind. A really, really, really big one that they didn't really talk about is fear of seeking care during the pandemic. I think we've seen this globally, particularly in the U.S. We've definitely seen a drop-off in utilization of healthcare services that started to go back up, but during this initial period of the pandemic where everything was shut down, a lot of people were afraid to take their children anywhere, let alone to take them to the doctor for even routine things, let alone serious things. I've had patients call, on mommy call, who are really adamant about not wanting to take their kid anywhere, but you're literally telling them, I really think that your kid should be seen. And so just that general fear of taking your kids anywhere or seeking care would be something important to for future studies, I think. Just the given stress and emotional impact of a global pandemic. I think we've seen it time and time again that kids pick up on stress, and having schools closed and not being able to see their friends or go anywhere or do anything, and then just the impact that it's had on their parents and parents losing jobs. I think children have picked up on that, and we all have seen, or we all know that, stress can lower your immune system. So is that causing them to get sick and then causing them to, kind of tipping them over the edge into diabetes? It's not something that we know, and it wasn't something that was talked about in the study. And then just duration of symptoms. We don't necessarily know if these kids were having symptoms at home for 2 months or 2 weeks. So that would have been something important to discuss. And then also just other ethnic backgrounds. So we're not really quite sure about the breakdown in Germany, and then that would be difficult to generalize it to our patient population. I did find an article that was published in May in the Journal of Clinical Endocrinology and Metabolism. And it was basically looking at racial and ethnic inequalities in young adults with type 1 diabetes. This study looked at, they classified young adults as those between the ages of 18 and 28 years old. And what they found was that in non-Hispanic, Black and Hispanic patients in their population, they actually had a higher A1C level. They had lower diabetes technology use. And then they also had increased reported distress when it came to their diabetes, and then just lower self-management. So showing that there obviously are disparities between different racial and ethnic groups. And I think that would be something important to look at in the future, and kind of why this would be difficult to generalize to our patient population. So just in terms of future studies or where they could potentially go in the future for this. So I did find an article, it was a cross-sectional study of Italian pediatric diabetes centers between February and April, and they looked at last year and then this year as well. And they found in their patient population that severe DKA was noted for about 44% of their patients this year versus 36% last year, and that this was a statistically significant difference in their patient population. There was also another study done out of Northwest London that looked at new onset type 1 diabetics and DKA from March until June. It included 5 inpatient units and in total had about 30 children. They were between the ages of 23 months and 17 years old. So out of the 30, 70% of those, so 21 presented with DKA, and then 52% of those presented actually in severe DKA, showing that there might be some link, but they didn't delve deeper into what the link could have been. I think something that could be important going forward is actually testing these patients for coronavirus and then seeing what the correlation is. We know that there is an association between viral infections, but seeing that if actually being diagnosed with coronavirus or having coronavirus-like symptoms is actually increasing the incidence of DKA or severe DKA, like that one study from China showed. I think going forward in the future as well, taking into account some of those confounding factors we talked about would be important, and then just having a longer study duration period, looking over a longer period of time to see like if there's a true effect. I think importantly, coming up in the next few months as we go into the winter, there is an association with diabetes and DKA during the winter months. Likely, a lot of studies think it's likely due to just infection risk, and seeing if there is a increase in that uptick of DKA during this time period coming up soon. So I think that there's a lot of room for more studies to be drawn and just more data as we continue to go through this pandemic. And I think that was my last one. So just my final thoughts. The study does indicate an increase in DKA and severe DKA at the diagnosis of type 1 diabetes, and they showed that there was an increase in children younger than 6. I don't necessarily think we have enough information of some of those other confounding factors to indicate a true association. We do know for sure that we're seeing an increased incidence in type 1 diabetes every year, and it's projected to continue to increase. I think we need to really consider and continue to look at just the fear of people not wanting to leave their houses during global pandemic could be causing delays in diagnosis and treatment, which could be contributing to that increase in DKA. And then, like I said, just looking forward to the winter months and just seeing, I guess, what happens there. I think that was my last one. So my references. Oops. And then did you guys have any questions, comments, concerns?
Hi, Olivia. It's Dr. Nguyen again. If you can go back to table 1, I agree with your assessment of this study. I think it does a decent job of showing that there is an increase in DKA and severe DKA during the coronavirus pandemic compared to previous years. But then the next big question is, so what do you do with that information? Why is there an increase? Right. What do you attribute that to? And how does that affect your clinical practice? So if you look at this table, I thought it was interesting, and they didn't really comment on it at the top, the heading. They have, N equals 532, 503, and 456 to state the numbers of patients diagnosed with new onset type 1 diabetes. And it doesn't appear to be statistically significant as far as a difference over the years, which I'm not entirely sure how to interpret and how that applies to, plays a role into the conversation. But in my mind, it seems that if there's not really an increase in diagnosis of type 1 diabetes, but there is an significant increase in presentation of DKA, then that seems to lend more credence to the conclusion that it's due to just poor follow-up or people not accessing medical care. And I think one of the other studies that had brought this issue up did actually see an increase in the diagnosis of type 1 diabetes during the pandemic compared to previous years. So I'm not sure if it's...
I appreciate you guys for listening and participating today. I hope it was beneficial in some way for you guys.